Welcome to All Things Simplified. Today we're breaking down one of the most challenging and most commonly tested cardiac arrhythmias, atrial fibrillation, AF. Atrial fibrillation is not simply an irregular rhythm. It is a condition that can lead to serious complications, including stroke, heart failure, hemodynamic instability, and even death if not recognized and managed appropriately. Many students struggle with atrial fibrillation because the treatment algorithm can seem overwhelming. However, once you understand the clinical reasoning behind each decision, the algorithm becomes much easier to remember. First, we need to consider whether patient is stable versus unstable, time symptoms developed and comorbidities such as recent stroke, CHF, etc., when approaching a patient with atrial fibrillation, because management differs significantly. For example, an unstable patient, do not delay for anticoagulant. Immediate synchronized cardioversion, regardless of whether the arrhythmia has been present for less than or more than 48 hours. This patient is in imminent danger. The immediate threat to life outweighs the risk of dislodging a clot. Waiting for medications to work, rate control, or anticoagulation may allow the patient to die or suffer irreversible organ damage. A hemodynamically stable patient, there is adequate blood pressure and organ perfusion. Allowing time to consider the duration of atrial fibrillation, assess stroke risk, and treat patient with oral meds. Treatment is rate control with oral meds such as beta blocker, calcium channel blocker, digoxin if patient has a history of CHF or hypotension, amiodarone if refractory to BB or calcium channel blocker, non-dihydropyridine. Anticoagulate for 3 weeks after rate control. If a stable patient is still showing some symptoms, despite rate control, pay attention to the heart's rhythm. When it comes to rhythm control, time plays a major factor in treatment plan. The 48-hour mark is critical because it determines the likelihood of a blood clot, thrombus, forming in the left atrium. If symptoms started less than 48 hours ago, treat with electrical or pharmacologic cardioversion because the atria have not been fibrillating long enough for blood to stagnate significantly, hence risk of dislodging a clot during cardioversion is much lower. The risk of clot formation is relatively low during the first 48 hours. Restoring heart's normal sinus rhythm quickly improves atrial contraction, cardiac output, and relieves symptoms. We anticoagulant for 3 weeks for preventative measures until the heart regains its normal function. After 48 hours, the chance that a thrombus has formed rises substantially because the atria quiver instead of contracting, effectively causing stagnant blood, which promotes clot formation. If cardioversion is performed after 48 hours without first excluding a clot, the atria begin contracting normally again, causing existing clot to eject into the circulation. This can travel to the brain and cause an ischemic stroke or embolize to other organs. Hence, after 48 hours, before cardioversion, it is important to anticoagulate for at least 3 weeks, then perform a transesophageal echocardiography to confirm there is no left atrial thrombus, before proceeding with cardioversion if no clot is seen. After successful cardioversion, anticoagulation is typically continued for at least 4 weeks because the atria remains weak for a period, allowing blood to pool and new clots to form. If anti-arrhythmia drugs fail in long-standing AF, consider cath ablation or pacemaker. CHA2DS2-VAS score is used to assess patient risk for embolization. A score above 2 is considered moderate to high risk and anticoagulation is required. Takeaway: after 48 hours, the stroke risk becomes the priority, so anticoagulation or a transesophageal echocardiography is recommended before cardioversion. If less than 48 hours, the risk of an atrial thrombus is relatively low, so cardioversion is generally appropriate.